Now I invite Dr. Tintu to take us through the key points in managing capsulorhexis in the white and the black cataracts. Dr. Tintu has completed her long-term fellowship in anterior segment and is now working as a consultant in cataract and glaucoma services at Giridhar Eye Institute. Over to Dr. Jilu. Dr. Tintu. Sorry.
Okay, thank you. Good morning, everyone. My topic is on handling hypermature cataract, the blacks and the whites. So we'll be dealing with the challenges and how to tackle it. So the first challenge is there is no red glow in a mature or hypermature cataract. So the only way to visualize the anterior capsule is by staining the capsule. So uniform staining with trypan blue is very important when you deal with a mature hypermature cataract. When the capsule is well stained, you can see a well demarcated rhexis margin, both in white as well as in black cataracts. But a poorly stained capsule or patchy staining means you are inviting complications. So this is also a stained capsule, but there is no staining at the center part of the capsule and you can't visualize where your rhexis is going. You won't see the rhexis margin and you may not realize even if the capsule extends. So don't do such bad staining. Staining should be proper when you deal with a mature cataract. The only disadvantage of capsule staining is that it makes the capsule more brittle. The second challenge is capsular plaques or fibrosis. These are the areas of the capsule which are thickened and resist tearing. So initiate your rhexis away from the area of capsular fibrosis. Since the capsule is very thick, it's better to use forceps. Here, a microrhexis forceps is used to complete the rhexis. Since the fibrosis is confined to central part of the capsule, you can easily do a rhexis beyond the area of fibrosis. But whenever there is an extensive fibrosis, like in this case, it's very difficult to get a continuous curvilinear rhexis because you need to cut the rhexis at multiple places. Here near the side port area, we cut it with 1 hour. Now again with microrhexis scissors, we are cutting. The advantage of fibrosis is that it may not extend at the area of fibrosis, but there is a chance of zonal adhesions because of lot of manipulation. So be careful when you deal with a extensive fibrosis. The biggest challenge in a white cataract is raised intralenticular pressure. It's a challenge even for experienced surgeon. As soon as you touch the capsule, what you just saw was a Argentinian flag sign. Okay. So whether all white cataracts are intumescent? No. Okay. We can assess it preoperatively by checking the anterior chamber depth, anterior lens convexity, looking for fluid pockets, and even with the anterior segment OCT. So usually intumescent cataracts are seen in younger patients with swollen anterior cortical fibers. In such cases, usually the anterior chamber will be shallow with a convex anterior lens capsule. And when we initiate the rhexis in young patient, if there is a fluid leak, actually the intumescence comes down or the intralenticular pressure comes down and you can actually go ahead with the rhexis safely without much risk of extension. But in cases where there is no fluid leak, the intumescence remains the same and there is high risk of rhexis extension. Also, when you deal with a hypermature cataract, when patient presents to you, if the patient have a red eye or a painful red eye, always check the intraocular pressure. Okay. With raised intraocular pressure and shallow anterior chamber, if it's a phacomorphic glaucoma, or in case of phacolytic glaucoma where you have lens proteins in the anterior chamber, you should control the intraocular pressure and inflammation before proceeding with the cataract surgery. So we'll just see a normal rhexis in a hypermature cataract. This is a hypermature cataract after normal staining and putting visco. The rhexis was initiated with cystotome. There was little bit of fluid leak, but with cystotome itself, there is no extension, so you can easily do a rhexis here without much intumescence. Okay, this is also a hypermature cataract, but as you are doing the rhexis, we can see there are some folds in the anterior capsule. Like how Dr. Jilu have mentioned, this was because there is no support of the lens while doing the rhexis. mainly because it's an absorbed cortex, like in a Morganian cataract. Okay, so in such cases, because of the lack of stability, it's actually better to use a forceps to do the rhexis. So here, while doing the rhexis near the side port area, there is a tendency to extend. So the main wound was used, and intrata forceps was used to grasp the capsule and pull it towards the center, and the rhexis was completed. Whenever you are putting any instrument through the main wound, there is more chance of OVD leak and AC shallowing. So always make sure your AC is filled with enough OVD. When you have any suspicion of intumescence, then always better to do a 2-stage procedure or double rhexis. So we'll see how to do a ideal double rhexis. After staining the capsule here, since the AC was shallow, cohesive viscoelastic was used. Rhexis was initiated with a sister toe, and with a micro rhexis forceps, the mini rhexis or a small rhexis is started. Okay, it's better to use the side port because the OVD leak will be less when you use the side port. Once the mini rhexis is done, you can decompress the capsular bag by aspirating the cortex. And now, after decompressing the capsular bag, you have to enlarge the rhexis. For enlarging the rhexis, this is a micro rhexis scissors. Okay, that also can be inserted through the side port, and you can see the angulation of the cut. It should be tangential to your rhexis margin, because if you put a perpendicular cut, that cut itself can extend because of the centrifugal forces of the anterior sonus. So always make a tangential cut on the rhexis margin. And again, we are using a rhexis forceps to enlarge the rhexis. Okay, so this can be done through the side port or main port with micro rhexis forceps or with utrata forceps, depending upon your convenience or your comfort. This is also a intumescent cataract. Here you can see, initially while doing, we are using shearing force, but because of the tendency to extend, the rhexis is pulled to inside, or ripping force is used. Because there is lack of control, the main wound is used. So depending upon the case, or depending upon the intumescence or the elasticity of the capsule, you may have to change. Okay, so it's not an ideal case for a beginner, because you can't predict how your capsule will behave. Now, like how Kirtana have mentioned, unstable cuts, rhexis cuts, can extend at any point of time. So this was also an inside out cut. You can see how nothing was done and the rhexis just extends like that. Especially in intumescent cataract, this can happen. Okay. Even if there is no unstable cut, with our manipulation also we can extend the rhexis. So here, see, forcefully decompressing the capsule. I already told hypermature cataracts have a fragile capsule, and it can just tear if you manipulate the rhexis, the capsule so much with the instruments. Better to avoid sudden shallowing while doing the rhexis. So in this case, while doing the second rhexis or while enlarging the capsule, you can see there is fluid leak, OVD leak through the side port. Okay, and there is faults in the cornea. This shows there is AC shallowing. And see what happened when the instrument was taken out. The rhexis was already extended. So avoid sudden shallowing of the AC when you're doing the rhexis. This is for the beginners. When you're doing for the first time with a rhexis forceps or a rhexis scissors, micro rhexis scissors, you should know how big is your instrument or how the instrument have to be used. So this is a case when the micro rhexis scissors when I was trying to put the instrument inside, there was lot of resistance, and suddenly there was a giveaway, and it went and hit onto the capsule, causing extension and even a PC rent. So this could have been avoided if the side port was slightly made bigger, rather than struggling through that side port. With all these challenges, making an ideal size rhexis is always a challenge in white cataracts or intumescent cataract. Either it can become too big and get extended, or it can become small. So when it is small, you can extend or make it bigger at any point of time. This was a young patient with just cortical cataract which was aspirated. So after removing the cataract, the rhexis was made bigger after putting the cohesive viscoelastic with microrhexis forceps. You can do it at any stage. So this is a case where even after putting the IOL, the rhexis was made bigger. Because especially in the second case, it's a case of pseudo exfoliation also. In such cases, the risk of phimosis is very high if you end up in a very small rhexis. So to summarize, what are the things to remember? So always uniformly stain your capsule or paint the capsule with the dye. Don't overpressurize the anterior chamber, but maintain your anterior chamber. Avoid OVD leak and refill if required. Careful in case of tags, it can extend at any point of time. Keep rhexis forceps and scissors ready when you are dealing with a complex case. Titrate your wound and know your instruments when you are doing. Choose the technique and instrument wisely. Thank you.
Thank you, Dr. Tintu, for that wonderful talk.